morning, everyone. It's an amazing pleasure to be here and quite an honor, and had such a good time. It's been a brief week, but I've seen so much of Israel, and obviously a lot more I have to see. My pleasure to give you this talk today on making hips less scary in arthrogryposis. Let's see if I can figure out how to make this work. There we go. So the problem with hips positioning, of course, is that it makes walking very difficult if the hips are in the wrong position. If you have bad club feet, you can learn to walk on them. If you have severe knee contractures, you can learn to walk on them. But if you have hip contractures, then you cannot physically get your foot in the right position for walking. There's two styles of hip deformities in arthrogryposis. There's the congenitally dislocated hips, and there's the severe contractures of hips. So we'll start off talking about the dislocated hips first. So about 30% of babies with arthrogryposis have dislocated hips. These occur much earlier in gestation than idiopathic. It's going off on its own. Okay, these occur much earlier in gestation than in idiopathic hip dislocation, probably someplace in the before 20 weeks of age, and that makes them harder to locate and makes them stiffer. And the common practice has been if the hip is out, you leave it out, particularly if it's both bilateral hips. If you have one hip in, then maybe you put the other one back in. And this is all supported by a number of articles that we've had over time, opinion pieces. But if you look at what underlies all those articles, it actually goes all the way back to 1961. This brief passage in JBJS British was a podium presentation given where Dr. Hansen here was talking about his experience with arthrogryposis, discussed 70-some patients. And if you notice, there's no data given. But at the very end, he said when one hip was dislocated, the operation was worthwhile, but not when both hips were affected. And this is what everybody else has keyed off of when they say don't put the hips back in. There's actually been a number of articles that have come out since 1986 saying, yes, if you put the hips back in, it's achievable, you can have good results with it, and you can actually help with walking. My philosophy has always been that the reason for putting hips back in the typical child is that it improves their gait efficiency, and the same thing with the arthrogrypotic child. And if you're hoping to get them to be good walkers as adults, you want to make them as efficient as possible because they already have enough difficulties ambulating as is. And it's also been my feeling, having seen enough of these kids, that the hips have a limited range of motion even before you put them back in. So what was to say that they weren't, that the limitation you're seeing in the range of motion after you put them back in wasn't what they already had initially. I like to do mine through a medial approach. I did it through an anterior approach for a number of years and started having difficulties with heterotopic ossification. So I went to the medial approach, as Lynn Staley had written about. My entry is between the neurovascular bundle and pectineus. I just find that's an easier way to go through. And then, as Mark was saying, I like to retain the ligamentum teres. This was a technique that I actually learned in India when I was traveling there. And essentially what you do is you just loosen it up from the acetabulum, get your hip reduced, and then you secure it down back to the acetabulum. The way I like to do that is take a suture and bring it up through at the root of the pubis, bring it into the acetabulum, and then go back through out the acetabulum. So you have a loop of suture within the acetabulum. And then I will bring my ligamentum teres up through that loop, like so, and then tie it down on the other side of the bone. And that'll hold it in place and tether it nicely. And the concern has been, well, doesn't that actually make things stiffer? And my results will show you that it really doesn't seem to make a difference to how that works. So for our latest review, we had 40 patients that we looked at that we had more than 2 years of follow-up on. Here's our results. But to kind of trim this down a little bit, the average age that we operate on these children was 22 months of age. I usually look to go between a year and 18 months if I can do that. But I've had children here 48 months, and I recently had one that's almost 5 years of age that I operated on. And the average follow-up time is almost 4 years. Did femoral shortenings in over 2/3 of the kiddos, usually about 12 millimeters, but sometimes I go to 24 millimeters. And if we look at total arc of motion, what we see, now in red is what's significant. So if we look at the same hip before the procedure and after the procedure, you see in the flexion and extension arc, we've only reduced it by 4 degrees on average. Abduction, adduction reduces by 2 degrees. Internal and external rotation, those decrease more significantly, just under 20 degrees for both of those. And when we looked at the kiddos who had unilateral hip dislocations and compared those to the dislocated side to the undislocated side, what you'll find is that the flexion extension arc has a difference of about 4 degrees. Both pre-op and post-op, it goes up to 5 degrees. That's the total difference that you have between those two sides of flexion extension. Abduction, adduction, it's 11 degrees initially, and at follow-up, it's 4 degrees. And actually, that becomes significantly improved after you relocate the hip. The typical dislocated arthrogrypotic hip is flexed, adducted, and externally rotated. And if we look at each one of those, we see that in the top row there, that's the flexion contracture they have. Those that have flexion contracture over 20 degrees. Preoperatively, it was a 33-degree flexion contracture. That came down to a 9-degree flexion contracture at follow-up. Lack of abduction in 33 of our hips, and that improved 10 degrees. Internal rotation went from 6 degrees short of neutral to 7 degrees past neutral, and that was an improvement. My biggest disappointment is that those hips that didn't have much flexion, we couldn't really improve on that. So the average hip that didn't flex over 90 degrees only flexed to about 70 degrees, and we lost a little bit of flexion on those. That was the minority of patients. That was only 12 patients, but that's still a concern for me. At follow-up, we had 26 of our 40 patients that were ambulating independently. 6 were non-walkers, and of those, most of them had some sort of a cognitive delay that became apparent over time. And then the other ones were currently walking with a walker, and I expect a lot of those will become independent over time as well. We did have about a 50% avascular necrosis rate, but half of those were type 1 avascular necrosis. I had a few that were type 3s, as you see in this picture down here. But still, it's a relatively round head within an acetabulum, and the range of motion does not seem to be impeded. Here's a typical type 1 on the patient's right or your left. And you'll see that that also seems to be doing well. The acetabulum is remodeling nicely. If you look at hip instability, we had a range of these. Most of them were grade 1 or grade 2. 12 of them so far have gone back and done a pelvic osteotomy, 5 of those with a varus derotational osteotomy. And that actually improved. It brought the numbers that were grade 1 from 41 to 52, decreased the grade 2s, and decreased the grade 3s significantly. The second grade 3 I've not yet operated on. But so these have actually improved significantly. There were no frank redislocations. Actually, I have to take that back. There was a patient who had, after her operation, had bilateral hip infections. We were able to get her through that period. When she came out, her hip spica looked good, and then about half a year later, started noticing that both hips came out, so I had to reoperate on her and get both her hips back in. So my conclusion is that the open reduction of the hips does not lead to greater hip stiffness. And here's one patient just to show you her feet. There's her hips, got them located. And here's some pictures that Mom had given me. And actually, the latest one I don't have, which is of her hiking with her parents out in the Grand Canyon area. How about the chronic hip dislocation? What can you do about this child who's 12 years old, walks with a severe Trendelenburg, flexes up to 90, but has a 25-degree hip flexion contracture? Well, this is one of those things that I learned from a friend of Mark's and mine about doing a pelvic support osteotomy, essentially making a proximal femoral osteotomy, rotating the proximal piece into as much adduction as you can so that you're supporting the pelvis on the intertrochanteric area of the proximal femur. Then you make 2 other osteotomies below that to get everything lined up well and to lengthen her out. Here she is at follow-up several years later. She flexes to 80 degrees, so she lost a little bit of flexion, but doesn't seem to be bothered by that. Has much less of a flexion contracture. And here is her video. Now, again, it's her left hip that's the one affected. You see she walks quite well. And she travels with her family to Kazakhstan for teaching English, is very active. What about hip contractures? Most hip contractures are multiplanar. There are some that are just purely flexion contractures. And for these, what I've started to do is what I call a percutaneous anterior hip release. So right below the anterior superior iliac spine, you can feel this tight cord, which is the conjoined tendon of the sartorius or tensor fasciae lata. And I'll take a scalpel just on the medial side of that and snip through that tight cord, and then keep on coming down the fascia lata all the way to just above the greater trochanter, and incise all that tissue there. And sometimes actually go a little bit further down to get the rectus femoris, or very carefully the fascia overlying the iliacus. And that can improve things quite significantly. So here's a child, 30-degree hip flexion contracture, showing you the ASIS with the red arrow and that tight band with the green arrow. And so we're just going to incise that down, come underneath the skin all the way to just above the greater trochanter. And just like this, you notice that when this is the only case I'm doing, I'll actually do this semi-sterilely. I'll just prep up the area and put on some sterile gloves and do this because it's a pretty small case. And just nip that down. And so in her case, we got her from 30 degrees down to 10 degrees with a very small procedure. And oftentimes we'll put them in a Petri cast so we can lie them on their stomach and keep them stretched out. The more typical contracture, though, is the abducted, flexed, and externally rotated contracture, like you see here. And the problem is that it causes, obviously, problems with walking, but sometimes even causes problems with sitting because their knees are so far apart they can't sit in a regular chair. So we came up with something called the reorientational osteotomy. Essentially saying, I'm going to leave the ball in the socket where it wants to be, but I'll make an osteotomy here in the intertrochanteric area and bring the rest of the leg down to where I want it to be. So I'm using the same range of motion. I'm just putting the leg in a different position to take advantage of that as best as possible. So we see this young lady here. You see what her hip contractures look like. She had a 65-degree flexion contracture, adducted to 35 degrees short of neutral, and lacked internal rotation. So we made here's her x-ray. This is her just lying down, what her x-ray looks like. Made, for our purposes here, a bone model that looks like her. And so what we do is we put the hip in its natural resting position on the operating room table. I'll put what I call a pelvis marking wire, axis wire, from anterior superior iliac spine to anterior superior iliac spine. So I know what the axis of the pelvis is. And I'll put a guide wire into the proximal femur parallel to that pelvis axis wire, regardless of the position that my femur is in. So you see that wire right there, going in there. And it'll have in many cases, a very oblique direction, as you're noticing here. And it's not unusual to have essentially bicortical purchase with this wire. It looks very strange. Then a cannulated seating chisel, go directly over that wire and go perpendicular to the plane of the pelvis or to the floor of the operating room table and drive it in that way. The whole idea is that where that seating chisel is going in, when you make your osteotomies, the leg's going to lie next to it, right in the corrected position, taking care of your flexion contracture. So you drive that in, you get two cortical purchase in this case. And then we make two osteotomies. Our first osteotomy is going to be about the typical one, about 5 to 8 millimeters below the seating chisel and parallel to the seating chisel. Second osteotomy is just perpendicular to the shaft of the femur. So we're taking out a triangular wedge of bone. And I usually have to strip the iliopsoas completely off the fragment that I'm taking off. So taking off with a complete sleeve of periosteum. So it's not loose, it's actually attached to a sleeve of periosteum. That allows me to take out that section of bone. So there's after my first osteotomy. There's my second osteotomy. Take that out, put the two pieces together, and then just use a 90-degree cannulated blade plate, put over it, connect that down. And that's what that looks like. And then oftentimes if you have a severe flexion contracture, you'll have this bump of bone in front that we need to take off, or else that's going to impinge when we flex up. I had some problems with that in the past, and so I realized to just trim that off, and that allows more free motion. So we have this child here, and after we correct him out, he looks like that. Now you say, well, his hips are still flexed. So that's because his knees have 90-degree flexion contracture, so I couldn't lay them down any flatter for this picture. But here he is up several years later, up and walking. I'll put him in a Petri cast for a total of 6 weeks. At 3 weeks, we'll get x-rays. If we see bone healing, we allow them to start standing in the Petri cast. And then when the cast comes off, we put them in KAFOs and get them up walking immediately in those. And we published this a year ago. We had 65 patients, of which we had more than 2 years of follow-up. So here's this child. This is what she looks like on the operating room table at rest. There's her x-ray pre-op, and then here's on the, your right is her x-ray several years afterwards when she's actually remodeled her osteotomies. We looked at range of motion just before surgery, at the time of hardware removal, and at the latest follow-up. And we looked at ambulatory status. And again, here's all our results, but to trim it down, 70% of these patients had the typical arthrogrypotic contractures of flexion, abduction, and external rotation, just like these children. And if you look at the top line there, most of them had flexion contractures of greater than 20 degrees. The average contracture is about 52 degrees. We brought that down to 15 degrees. but the range of motion, the flexion extension total arc of motion, actually improved. It went from 73 degrees to 85 degrees. And I think that improvement just came because as they're walking, they slowly stretch out a little bit themselves. They all had lack of adduction, but that improved from 20 degrees short of neutral to 20 degrees past neutral. And their internal rotation also improved. Here again, though, I could not get the ones who had lacked hip flexion to improve significantly. So 25 of these had a limitation of hip flexion, about 63 degrees preoperatively, went up to 74 degrees postoperatively, but it still wasn't as much as I would like for good sitting. Preoperatively, I had 6 patients who were ambulating. At follow-up, 36 patients who were ambulating. And some of these were still walker dependent, but we expect them to improve. 9 were non-ambulatory. Some of these we just did for seating purposes alone. So here's one child. This is what she looks like. That's what her x-rays look like lying down. Here's after the operation. Now, what's interesting is that that upper lateral point on both sides looks like a greater trochanter. That's actually where we've cut through her shaft. But look what happens as she remodels. She actually brings her greater trochanter from straight posterior back up into a normal position. And here she is many years later, up and walking. Thank you very much.